Ευχαριστώ. Kalimera. Unfortunately, my Greek is not that good, so I'm going to speak in English. I greatly appreciate the invitation. I thank Dr. Katsukidakis and Dr. Savopoulos and Dr. Tabakopoulos for the opportunity to speak here today. My presentation is called Best Practice Approach to Nausea and Vomiting. So thank you again for having me here. These are my disclosures. None of them are relevant for this presentation. I don't have any affiliation with any of the drug companies that will be mentioned in this talk. The objectives of this talk is to identify mechanisms involved with nausea, triggers that induce nausea and vomiting, and also to look at treatment options for nausea and indications for their use. Now, nausea and vomiting, as you know, is a common symptom, and the etiology of nausea can be quite complex. There's many conditions that are associated with nausea, and it would be too broad to discuss all the clinical scenarios and their workup. So I'm going to focus on the nausea basically when it occurs and what the treatment options are for these. Let's go over the definition of nausea and vomiting. Nausea is, as you know, the sensation of nausea that you're about to vomit. It can occur alone, but it also can occur with vomiting. Vomiting is a complex mechanism of the GI tract that results into expulsion of gastric contents. The mechanism is a contraction of the stomach muscle, relaxation of the lower esophageal sphincter, and initially constriction of the cracopharyngeal sphincter, and then relaxation as the gastric contents come out. So it's a fine orchestrated mechanism that the body has. Retching is the gagging is the mechanism, but without any gastric contents coming out. Regurgitation is something else. That's actually gastric contents coming up in the hypopharynx with little effort. So a little bit different definitions here. So it's important to find out what is the cause of the nausea in the patient, and then to look at non-medical treatment options and then medical treatment options. And those can be either one drug or a combination of drugs, and there's some other options that I'll discuss as well. So you can look at the nausea and ask your patient, when did it start? How often do you vomit? How bad is it? How severe is your vomiting? Is there any relationship to the food that you consume, or is there any relationship to any medications that you use? Have you started a new medication recently? Are you using any antiemetic drugs recently? Have you been nauseous for a long time, or is that something that started recently? Are there any things that help you with the nausea or anything that makes it worse? You may see that this has some similarity to the questions that you would ask somebody with pain. So you can ask similar questions for nausea and vomiting. Now, I'm going to categorize the etiology of nausea into 4 different centers in the brain that will help us to understand how nausea is processed in the brain, and also it will help us to find receptors that we can treat with drugs. So there's the vestibular system, which is affected when you have motion sickness on a boat, on a plane. In the same vestibular system is affected when you have vestibular neuritis or Meniere's disease. Meniere's disease, as you know, is loss of hearing and vertigo, and usually accommodated with nausea and vomiting. The receptors that are associated with the vestibular system is muscarinic acetylcholine receptors and histamine type 1 receptors. And that's important to remember because that will affect our treatment later on that I'll discuss. The second zone in the brain that is important in the process of nausea and vomiting is the chemoreceptor trigger zone. It's the area postrema at the base of the 4th ventricle in the medulla of the brain. The etiology of nausea that is mostly affected by this system are drugs, most commonly opioids, but also antibiotics, NSAIDs, or selective serotonin reuptake inhibitors. The chemoreceptor trigger zone is also affected by uremia, hepatic disease, infection, dehydration, electrolyte imbalances, or endocrine dysfunctions. All these diseases primarily, but not only, affect the chemoreceptor trigger zone. And the receptors that are important here is dopamine type 2 receptors, 5-hydroxytryptamine type 3 receptors, or serotonin type 3 receptors, and NK1 receptor, neurokinin 1 receptors. And there are drugs to address all these 3 receptors, which I'm going to discuss in a little bit. The third area of the brain, or let's say the body, is actually peripherally is mechano and chemoreceptors that are in the gut, at the mucosa, the viscera, and these receptors primarily act via vagal responses and are transmitted to the brain. The diseases that are primarily targeting these receptors are constipation, gastroparesis, gastric outlet obstruction, gastroesophageal reflux disease, eosinophilic gastroenteritis, postoperative nausea and vomiting is primarily these receptors, but also the chemoreceptor trigger zone. The traditional hangover, when you had too much ouzo the day before, that's also these type of receptors. Chemotherapy and pregnancy as well. Pregnancy is a little bit more complicated because it does affect the other areas as well, but I just put it in this list here. The receptors for the peripheral mechano and chemoreceptors are primarily 5-hydroxytryptamine type 3 receptors. And then there's the cortex of the brain. So increased ICP, increased intracranial pressure, is primarily located in the cortex. Migraine headaches, pain, anxiety, cyclic vomiting syndrome, and rumination syndrome are also diseases that primarily target the cortex. Rumination syndrome is a postprandial vomiting that you can see in kids and adolescents. The receptors that you would target here are muscarinic acetylcholine receptors, histamine type 1 receptors, and 5-hydroxytryptamine type 2 receptors. So this is a complex slide, but it does contain some of the information that I mentioned in the slides before, but it kind of puts it all together. If you can see here, let's look again at the vestibular system. You may remember I mentioned the 4 system, which is the vestibular, cortex, chemoreceptor trigger zone, and peripheral pathways. So let's focus on the vestibular system. I mentioned muscarinic acetylcholine receptors and histamine type 1. Those are with the motion and labyrinth disorders. This vestibular system has projections to the chemoreceptor trigger zone as well as to the vomiting center, which then results into the nausea and vomiting. The next one is the chemoreceptor trigger zone. Also has projections to the vomiting center. Here are the receptors that I mentioned. And then you have the peripheral pathways via the vagus nerve, but also splanchnic, glossopharyngeal, and sympathetic ganglia towards the vomiting center. The cortex directly has projections to the vomiting center. And then this results into the nausea and vomiting. You can see that they all have connections to one another and all result into this mechanism of the vomiting. So what are the treatment options? Let's look first at options without any drugs. So there's things you can do to help patients, which is reassurance, relaxation, the correction of dehydration, electrolyte imbalances, if that is the reason for the nausea, decompression of the stomach if you have gastric outlet obstruction, treatment of constipation, oral hygiene helps, reduction of meal portions and use of cold food, reduction, elimination of tube feedings, and avoidance of odors. So this all helps in patients that have chronic nausea. But often that's not enough. You need some drugs to help alleviate the nausea and the vomiting. So here it's important, and that's why I mentioned the 4 system. These all have the receptors that I mentioned, and you can adjust your pharmacotherapy to the receptors that are caused by the primary disease. So if you have the chemoreceptor trigger zone, you would target D2 and 5-hydroxytryptamine type 3. So you would use drugs, dopamine receptor antagonists and serotonin receptor antagonists. If you have the cause of being in the vestibular system, you use antihistamines and antimuscarinics. If the cause is in the cortex, you use antihistamines and anxiolytics. For the GI peripheral pathways, you use dopamine receptor antagonist, serotonin receptor antagonist, and neurokinin type 1 antagonist. And I'm going to go over these drugs right now. These are the generic drug names as well as commercial brand names that are used in the United States. They might or might not be different in Europe. So if we focus just on the generic drug names, then you can see what is available in Europe or in Greece, because there might be some differences. So dopamine receptor antagonists have been around for quite a long time. They're usually benign, but they have the side effects of dyskinesia, as you may have seen. So that's why, for some reasons, they're often not used as much anymore. But Reglan is probably the most common, or metoclopramide, one of the most common anti-nausea medications. But there's also chlorpromazine, droperidol. Droperidol, you probably know that there's a black box warning because of QT prolongation with incidences of cardiac arrest. So because of that, droperidol is not used as much anymore, but recent studies have suggested that if you use it appropriately and not dose it high, that the risk of QT prolongation and cardiac arrest is probably very low. So it's not as unsafe as people think it is. But there's also prochlorperazine and promethazine. Are you familiar with these drugs? Are these available in Greece? Yes. Yeah? Good. And then what is more frequently used recently are the serotonin receptor antagonists. Ondansetron, which is Zofran, is probably one of the most common ones, but there's newer generations of serotonin receptor antagonists such as granisetron, tropisetron, dolasetron, and palonosetron. They're all pretty similar. There's studies comparing one to another, but there's not any significant difference between one or the other. Interesting, though, recently palonosetron was introduced, which has a very long half-life. So if you want of 30 to 40 hours, if you need a drug that has a longer duration, that would be the one to choose. A newer generation of antiemetics is neurokinin type 1 antagonists, which are, for example, aprepitant, fosaprepitant, which is the IV form of aprepitant, netopitant, rolapitant, and casapitant. Are these available in Greece? Yeah? Good. And then there's, of course, the antihistamines, such as buclizine, cyclizine, diphenhydramine, diphenhydramine, and meclizine. I'm sure those are available as well. Those have been around for a while. And then anticholinergic and antimuscarinic drugs, hyoscyamin and scopolamine. Scopolamine patch is something that's available here? Yes. Yeah? Good. And then promotility agents are metoclopramide, Reglan, as well as erythromycin. And then you have other treatment options are dexamethasone and lorazepam. So you basically addressing the cortex, benzodiazepines or steroids help especially in cancer patients that undergo chemotherapy. So let's look at major categories of nausea and vomiting and how those are addressed. So opioid-induced nausea and vomiting is something that's very common. The effect is that the opiates directly affect the chemoreceptor trigger zone in the medulla and cause nausea. So that based on the receptors that are located there, you can use dopamine type 2 antagonist, haloperidol, metoclopramide, prochlorperazine, and chlorpromazine. And what you can do is also switch opioids. For example, switch from morphine to dilaudid hydromorphone. That sometimes help, or fentanyl patches. You might be able to help with the nausea in that case. Very common is chemotherapy-induced nausea and vomiting. There's plenty of research on how to address that. The pathway is primarily serotonin receptors in the mucosa of the gut and the viscera going via the vagus nerve to the brain, and then, but also the chemoreceptor trigger zone. So two major pathways. The treatment options are serotonin receptor antagonists, most commonly ondansetron, granisetron, and the others that I mentioned before. And oncologists usually combine This with a neurokinin type 1 antagonist, a prepitant, and the other ones, and a steroid. Here you have to look at which cancer the patient has, what chemotherapy is being used, and that would alter your regimen for the antiemetics because there's certain preference that you have depending on which chemotherapy drug is being used. But usually a triple therapy seems to be most effective. For gastric stasis, this can be caused by drugs, most commonly opioids, or anything that compresses the stomach from the outside, such as an enlarged liver, ascites, or a tumor in the liver that kind of compresses the stomach, or an intrinsic outflow tract obstruction, which can be peptic ulcer disease or a tumor in the stomach can cause gastric stasis. The symptoms that you see is epigastric discomfort, fullness, early satiety, exacerbated by eating and relieved by vomiting, and also most commonly with large volume vomits are being seen in these patients. What can you do? You can use a prokinetic agent to help emptying of the stomach, Reglan being one of the most common one. But domperidone is a dopamine receptor antagonist which has a bit less side effects, less dyskinesia. You can use proton pump inhibitors and steroids as well. One option is also cyclizine that has been reported with this condition. Malignant bowel obstruction is primarily causing a stimulation of the chemoreceptor trigger zone. Here you can use Haldol, Reglan, fluorocorperazine, chlorpromazine. You can also consider octreotide or dexamethasone. Usually you attempt a decompression of the stomach. One of the most common causes of nausea vomiting is your motion sickness, seasickness. As I mentioned before, it affects the vestibular system. Here you can use scopolamine or hyoscyamin. And usually the most effective combination would be with antihistamines such as diphenhydramine, promethazine, meclizine, or piperazine. If you have patients with increased intracranial pressure, this via the cortex is directly stimulating the vomiting center. Here you have to first treat the cause of the increased pressure, maybe a drain hole to release the pressure, but then also use mannitol, for example, or steroids to decrease the intracranial pressure. And for drug options, you have the antihistamines, diphenhydramine, or promethazine being the most frequently used. Here are the causes: intracranial tumors, cerebral edema, intracranial hemorrhage, meningeal infiltration by tumors, skull metastases, or cerebral infection. If it comes to drug dosing, it is important to remember that you should use the appropriate doses, not underdose, but give them what they need, and schedule around the clock. So giving it when nausea occurs is not a good option. It's better just to continue it scheduled around the clock. General guidelines are not to use more than one drug from each class. So if you use ondansetron, it doesn't make use to add granisetron. You'd rather than use different drugs such as neurokinin 1 antagonists. You can consider less traditional medications such as dexamethasone or lorazepam. You can consider alternative routes, topical, rectal, subcutaneous, because when patients are nauseous and vomiting, often they can't tolerate an oral medication. And be alert for drug interactions. In patients with cancer, you could consider palliative sedation if the cancer has progressed. I'm going to talk briefly about alternative techniques. That's not my area of expertise, but I do want to mention them. Here you can see a person going to the acupuncture, bring a voodoo doll, and she says, just give me treatments once a week with the voodoo doll. Not sure if that's effective, but acupressure is something that has been shown to be effective for pregnancy-induced nausea and vomiting, the morning sickness. The pressure point is right here. It's called the P6 Ni-Quan pressure point. It's about 3 fingers breadths proximal to the wrist and can be compressed here. There's some bands available, the C band, which provides pressure at this point. There's some studies that show that this seems to be effective in pregnant women. Some other studies, prospective randomized trials, that show that it's not beneficial, but it's so benign that that's certainly something you can consider for a pregnant patient. Acupuncture is something you can do. Here you see a patient with acupuncture, and it says, "You got to be kidding me, your back still hurts." So you just have to, most importantly, find the right points where you address your acupuncture. It would be the same P6 point at the forearm that you use for acupuncture. Generally, it's believed to be helpful in chemotherapy-induced and postoperative nausea and vomiting. Aromatherapy you can try, very benign, doesn't have any side effects. So oil of mint is something that seems to be helping in these patients. Other non-traditional medications are pyridoxine and doxylamine. Pyridoxine is something that has been used in pregnant patient, has not been shown to cause any birth defects, so it seems to be safe in pregnancy. It's an antihistamine and is sedating. Cisapride is another medication, a serotonin type 4 agonist. It causes prolonged QT, and it's only available for compassionate use for nausea and vomiting. Ginger lollipops is something that I read can also help with nausea and vomiting. Now it's getting more interested. Marijuana is something that can be used for nausea and vomiting. The active component, which some of you might know, some don't, is 9-delta-tetrahydrocannabidiol, THC. It helps with nausea and vomiting. It also induces hunger, which helps in patients that undergo chemotherapy or in AIDS patients because they don't have much appetite. So you can use that to your advantage. Provides analgesia as well, and it lowers your intraocular pressure. So why would we not use it? Smoking is the most common option to consume marijuana, but as you know, smoking has side effects. And most importantly, the effect decreases after 30 minutes. You can vaporize it to avoid the side effects of smoking. It's safer and seems to be more predictable. Or you can ingest it, but that peaks after 2.5 hours, and the effect declines over 24 hours. So it's a quite prolonged effect. There is some pills available for containing tetrahydrocannabidiol. Are those available in Greece? Do you have THC pills? No? Yeah. In the United States, something that's available is Marinol, which is containing THC. And there is, in Canada, there's Nabilone, Casamate. And there's another one, a mouth spray for MS patients called Sativex. These are some drugs that are available, but they have some downsides to them, abuse being one of the most common problems with THC medications. But they do help patients where traditional methods have been unsuccessful. And they help patients who have consumed marijuana in the past. They're not very helpful in elderly patients with no prior experience. Some benefit for nausea, appetite, and pain. Other drugs seem to be at least as good or better, so you might be successful with other drugs as well. Research data is poor, and as I mentioned, a high risk for diversion and abuse. So the summary of my little presentation here is if you address nausea and vomiting in patients, first to identify the most likely etiology and the mechanism involved. And most importantly, you have to treat the primary disease that is causing the nausea. But then the next step would be to choose the medication that addresses the receptors that are associated with the etiology, and use medications that would be most effective. And then to dose it appropriately, usually on a scheduled basis. And if ineffective, you can consider multi-drug regimens, which is common, for example, for cancer patients. And then finally, you can consider less traditional interventions and medications as well. Ευχαριστώ. I'm happy to answer any questions you have.